Good afternoon, good day, everyone. So I'm John Polido, a PhD student at the University of Trieste, and I'm working here at the Italian Liver Foundation. And today, I'm given the privilege to introduce our yellow webinar speaker. So our yellow webinar speaker for today obtained his medical degree in medicine and surgery in 2002 and pursued his postgraduate education in pediatric emergency and neonatal pulmonology in 2003 and 2004 respectively, prior to his specialization in pediatrics as a subspecialty in neonatal care in 2007, and his PhD degree in biochemistry and clinical molecular biology in 2012 at the Catholic University of Sacred Heart, Rome, Italy. In 2012, he was also an associate professor of pediatrics before becoming a full professor of pediatrics in 2016 under the National Scientific Habilitation by Italian Ministry of University of Research. Between these years, he obtained his MBA in hospital management at Haute École des Mines Paris-Tech in 2014. And in 2018, he completed his habilitation to direct research in pediatrics at Sorbonne, Paris Descartes University. Currently, he is working as a full professor of pediatrics in neonatology at Paris-Saclay University since 2021, chief of the Division of Pediatrics, Transportation and Neonatal Critical Care at the Béclère Hospital, GHU, Paris-Saclay since 2013. He is involved as a coordinator or local PI in several international multi-center randomized clinical trials and has been granted a total of more than 2 million euros of research fundings from both public and private institutions over the last 10 years. He has authored more than 300 articles, of which approximately 70% as first or last author and 60% in journals in the first quarter of pediatrics or critical care fields, which include major titles such as JAMA, Lancet Family Journal, Nature Communications, Intensive Care Medicine, and American Journal of Respiratory Critical Care. He is currently the editor of the European Journal of Pediatrics, Springer Verlag since 2018, and still has many editorial activities in different publishing groups as editorial board member and associate editor, and has been the chair and speaker of many international conferences and seminars. He was the past president of the European Society for Pediatric and Neonatal Intensive Care. Currently, he is chair and coordinator of many ongoing projects with active collaborations in both academy and industry, aside from his several teaching activities. He has a long list of honors and awards received due to his scientific, professional, and humanitarian merits, including the Trophée Apinov in 2013 by the Assistance Publique Hôpital de Paris, which is awarded every year to the most important medical innovation produced in Paris, and most notably as a Knight of the Italian Republic, which was awarded for merit acquired by the nation. The Order of Merits of the Italian Republic is the highest ranking honor of the Italian Republic. Without any further ado, let us welcome our yellow webinar speaker, listed amongst the top Italian scientists in clinical sciences and the Stanford University names world's top 2% scientists, and a neonatologist with advanced clinical expertise in cardiorespiratory critical care, as well as complex perinatal care, including the neonatal jaundice, which he will be presenting about the news about the diagnosis and management. Professor Daniele De Luca.
Thank you. Thank you very much for the kind introduction. I'm flattered, actually. I didn't expect all this. And it's a pleasure for me to be here and to meet you guys. It's also very, very rare for somebody like me, you know, for a neonatologist to be invited by a group so well renowned in research in adult clinical medicine and particularly in hepatology. I have followed Professor Thierry Belli steps and works all over the years. And funny enough, we never met in person. But eventually, we, as you can see, we crossed our paths also thanks to our common friend, Vinny Butani, who put us in contact. And I personally believe that one driving force behind us is multidisciplinarity. We cannot do very much innovation in neonatology, neonatal medicine, without looking at adult medicine. Probably the contrary is not true, but for us, this path is vital. As much as almost every single innovation that has been introduced in neonatal medicine has been brought, modified, amended somehow from adult medicine. So I'm here today to tell you nothing really new, actually, but just to give you a clue and insight about what is happening in the world of neonatal jaundice and so for babies. Let me just try to share again my slides that actually, yeah. Now, jaundice is the most common neonatal disorder. On average, 70% of newborn infants suffer from some sort of jaundice. Actually, we cannot actually say that all this 70% is a disorder. Most of the time is just a physiological feature related to the, let's say, liver learning to do its job once the placental circulation has been cut down. But obviously, since black and white does not exist in life, but there are several shades of gray, like the book, I would say, there are cases when physiology becomes pathology. And there are also other cases where, on top of the physiological mechanisms, there are others that are absolutely not normal. The physiological mechanism is a sort of a delayed elimination of bilirubin because the liver is still not working at the right rate after the interruption from central circulation. And I'm talking about the liver enzymes. But the pathological side of the history is coming from the bilirubin production. So every time there is an increased hemolysis, basically for allo immunization between the mother and the baby, and we now know a lot of these antigens that can be able to produce alloimmunization. Once upon a time, it was just Rh. Now we know there are many others. Another cause for increased production of bilirubin is obviously polycythemia, which is relatively rare, but is also relatively common in some particular categories of babies, and some red blood cell defects. Now, this is the foundation of what we know. This is what is more or less taught to every single neonatal resident or anyway, last year medical student when it got into the basic pediatric knowledge. Now let's try to see what happened, I would say, in the last 20 years, because everything I told you so far is relatively old. Now, in the last 20 years, or even a little bit more, the main innovation has been represented by this curve that we just published a few months ago in an international collaboration between Europe and America. The mortality due to extreme neonatal hyperbilirubinemia has fallen down significantly. Here you see 5 European countries. More or less, they follow the same path with just pretty much an inexplicable peak over here in Greece. But the very good news is that everything has started more or less here in the beginning of the years 2000, where the universal jaundice screening has been pushed and hopefully implemented in every single maternity ward around the world, thanks to the vision of Vini Butani working in Stanford. Imagine that before that here, babies were checked for the bilirubin level only depending on the physician opinion or the nurse opinion or their degree of yellowness, which is something very much subjective that was anyway not advised by the international guidelines. So starting from 1999, more or less, everyone has been advised to check everyone. I'll tell you later how, and you can clearly see how this has increased the detection of extreme hyperbilirubinemia. Would it be due to some deranged physiological mechanisms or to some pathological mechanisms like I resumed a few minutes ago? So now we are all at the same level, relatively very low actually, mortality, but we're not happy yet because that means it's not zero. Zero does not exist in life. And so extreme cases still exist mainly for, let's say, mistake during the screening and sometimes for organizational reasons, because particularly in countries like Italy, where there are way too many maternity hospitals. Those small hospitals are not equipped enough, or they do not know enough how to manage that. And even if they detect a baby with extreme hyperbilirubinemia, then there is a loss of time to refer him or her to hub to a referral center taking care of the case. And here is where the problems are coming. Now, in order to decide what is going to happen next, there are nomograms. So the nomogram is a concept very much common for pediatricians in general. Nomogram is a curve, like you see over here, that is drawing something on the y-axis, like the amount of bilirubin, the blood bilirubin, let's say, the total serum bilirubin, I'm sorry, versus some time. Here you see, for example, the hour of life from 0, 12, 24, and so on and so forth, right? So these nomograms here are the nomograms used to decide if the baby needs to be treated with phototherapy. And those are the very last ones that have been issued by the American Academy of Pediatrics just a couple of years ago. I've been consulting for that. And they changed significantly the nomograms that we have been using in 2005, so 20 years before. Why so? Because the threshold, this, let's say, colorful blue, red, green, yellow line has been brought more upper. So the threshold to start phototherapy has been increased. Conversely, the, let's say, shadow area with the same color over here has been enlarged. What does that mean? It means that when you trespass the threshold, obviously you need phototherapy. But when you are in this, let's say, colorful, shaded area, that's the at-risk zone. And that means that the baby must be checked more quickly, more serially, and bilirubin must be checked much more frequently. So all in all, this new policy that we have right now in place somehow reduced the need for phototherapy. So we are using phototherapy less than before, and I'll tell you why by the end of my presentation. But conversely, we are much more watchful, we are much more careful, and we test the babies much more because we want to be extra sure that perhaps this particular baby is approaching the line, is approaching the threshold, but is not trespassing it. Why there are many colors? Because obviously here we are talking about, as you can see here, phototherapy 37 weekers and more with risk factors in yellow. So it's a little bit lower. Phototherapy 37 weekers and more without risk factors in green. And then the upper curves are the curves for the exchange transfusion. Now, I'm sure that you have heard about exchange transfusion, which has been back in the 70s and in the 80s, the main and only therapy for neonatal jaundice. There's an extremely invasive therapy that needs a central venous catheter in place. I'll show you by the end, where basically we exchange the baby's blood. We remove the baby's blood for up to 2 times the volume of the circulating blood in order to remove bilirubin, obviously, eventually the antibodies that are generating hemolysis, and eventually remove also the red blood cells that have been hemolyzed with new ones, and eventually also provide albumin in order to reduce the unbound bilirubin that is circulating. So this is really extreme to be used right now. We have a problem circulating in our world that the young fellows or the young resident, they do not know how to do an exchange transfusion, which is an invasive, riskful, and pretty long procedure that is taking around 1.5-2 hours. So there is always somebody like me, middle age, or even senior than me, watching what is going to happen when a younger one needs to do an exchange transfusion. Now, I told you about the therapy, the main 2 therapies, right? So therapy and exchange transfusion, although this latter is extremely rare. There are a few others I'll tell you by the end of the presentation. But now let's do a step back and let's try to see what are the novelties in terms of diagnosis of neonatal jaundice. So you make a diagnosis before going into a therapy, right? So the main novelty has been, again, beginning of the 2000 years, the introduction of the 2nd generation transcutaneous bilirubinometry. So the idea to measure bilirubin through the skin without any invasive procedure, without any heel prick, without any blood drawing is not new. Has been tried even before, but the technology was not enough developed in order to translate a degree of yellowness, if I can say so, into an actual milligram per deciliter or millimole, micromole per liter or millimole per liter bilirubin concentration. The new technology using a much narrower wavelength analysis has allowed it correcting for let's say the amount of light that is reflected by other chromophores that are not bilirubin. And I'm referring to melanin, and I'm referring to hemoglobin, particularly because, as I said before, some babies have a very, very high hematocrit at the delivery and the following days, and we can talk about that during the Q&A session. So here, from a book that I wrote a few years ago together with Greg Jackson and Billy Engel, who are now retired, you see the first meta-analytical correlations after countless of studies putting together second generation transcutaneous bilirubinometry and the real total serum bilirubin. So you see, we are at 0.9 for term babies, 0.84 for preterm babies. Anyway, those are extremely high correlations. And this is why right now, even in my NICU, even in my division, which is the biggest neonatal division in France, one of the biggest in Europe, we do use transcutaneous bilirubinometry as a first line diagnosis tool in order not to draw blood to every single baby doses of times and to do a sort of a screening and save blood. I'll show you something more about that. So with the introduction of the transcutaneous bilirubinometry, we have been able to draw nomograms, but this time not to decide if we need for therapy or exchange transfusion, just nomograms to decide if the evolution of jaundice in that particular baby was physiological or not. We needed a reference, right? And this is what Vinny Butani did for the first time in 1999 with the total serum bilirubin. But again, this was invasive. Then we had the opportunity to do that in a non-invasive way, which eventually has improved the universal screening policy even more, because someone, as you can imagine, was a little bit, scary to do the screening, drawing blood and pricking all the heels of everyone every day. Now you can do that with the transcutaneous bilirubinometry without any harm. And this that I'm showing you here with a little bit of proud, because at that time I was a fellow and I won the European Young Investigator Award by Acta Pediatrica journal at the time, is the first and as far as I know, only European transcutaneous bilirubin nomogram available and used right now all across the continent. And so you can clearly see the difference in terms of bilirubin level for term babies above 37 weeks and preterm babies below 37 weeks. And those are obviously the 5th, the 10th, the 5th, the 25th, the 50, the 75, the 90, and the 95th percentile. And so you can see when you measure skin bilirubin using transcutaneous bilirubinometry twice, if the baby over time, on the x-axis you get the hours of life, if the baby over time is always following the same percentile or not. If it's not following the same percentile, so it's crossing the curves, that's a danger. That's the crossing centiles behavior that has to be recognized as something very dangerous. And it's very common for us as a pediatrician, because the classical pediatrician in an outpatient clinic does exactly the same, looking at the nomograms for weight and height in order to understand how the infant is growing, right? Now, we're not looking at the infant growth, we're looking just at the bilirubin development, where bilirubin is going towards a higher levels or let's say remaining stable and then going to the right. On average, a normal baby with a physiological jaundice is going to have a sort of a parabolic curve with bilirubin, let's say, going up not above the median level and then going down in like 2 or 3 days. But the reality is much more complex than that, because with time passing by, nomograms of skin bilirubin have been produced all over the world. I did the European ones, Billy Engel did the Hispanic one, and Richard Sampavat did the Thailand one, Taiwan. And then Jeffrey Meisels did the American one as well. And now I can tell you that there are many others around the world. But at that time, when I did this analysis and got published in JAMA Pediatrics in 2009, there were only 4. And from this curve, with all the nonlinear regressions fitting the data, you can clearly see how this parabolic curve that I mentioned before is different according to the genetic background, right? So somehow the North Americans who were a mixed, including also Black people, who are known to eliminate bilirubin quicker, in a more quickly way, and so to have less severe neonatal jaundice, are in an inferior situation, a better situation compared to us, and the Hispanic people conversely are going up and up again. So that means that there are significant differences according to the ethnicity, and it also means that everyone should use the nomogram closer to his or her background population in order to take into account the different ethnicity and the genetic background. So this is one of the transcutaneous devices that we have. Maybe this one is even no more available right now, but it's here just because I want to show you the difference between the human eye and the electronic eye. So remember what I said in the beginning. Before the advent of this technology, people were used to just have a look at the yellowness. I remember my nurses when I was younger, and just putting a finger on the forehead and say, hey, this is very yellow. Let's just draw some blood and check the serum bilirubin. This is what we were doing on a daily basis by doing rounds in a nursery. This was very much inaccurate. And now we also know that the electronic eye is more intrinsically accurate than the human eye. I'm sorry to say that in an era of artificial intelligence, but that's true, because you see, classifying the yellowness class in 3 categories, you can clearly see that the number of underestimation by the visual assessment was always higher compared to the underestimation when you also use the skin bilirubin measurement. And the same apply for the overestimation. So all in all, the number of errors have been reduced by the use of skin bilirubin. And this is basically why has been so useful and diffused all over the world. So I want to be clear right now, because I know the Professor Firibelli is listening to me. No, transcutaneously measured bilirubin is not serum bilirubin. That's a different thing, okay? Those two things are two closely related, but conceptually different variables, right? The bilirubin measured in the skin is the bilirubin that eventually went out from the circulation, entered into a tissue, namely the skin, right? And to do that, obviously, must have been somehow free from albumin, okay? Now, that's a lot of very old literature. I do not have the time to show you, explain this mechanism of the passage from the blood to the skin, and it's obviously influenced by the circulating albumin and by the level of blood pH, but this is what we know. So we are measuring something that is a proxy of the total serum bilirubin, not just to forget forever about the blood levels that are still measured and useful, and I'll show you, but just to answer the question, should I worry for this infant? This is what we do. We check skin bilirubin first, and if it's okay according to the nomograms, then we are okay. We will see that tomorrow. Otherwise, if it's not okay, and we're approaching the level of phototherapy, or even more extreme transfusion, but we're not going to get there before checking the phototherapy. You remember the first curve that I showed you with the different shaded colors. Then if we're approaching that threshold, we check the blood bilirubin, the total serum bilirubin, and we decide if we go for a therapy or not. So basically, transcutaneous bilirubinometry is very useful for screening, and the serum bilirubin check is used for deciding about the therapy. And it's also useful to decide about, let's say, the continuation of a therapy, or anyway, the need for a second session. You see here a baby under a sandwich phototherapy. We demonstrated, as you can see over here in this correlation graph, that when you measure skin bilirubin on a covered, on a shielded skin area, the correlation is very good, even during phototherapy. But then we know that to become really, really accurate again, you need at least 18 to 20 hours after the end of phototherapy, because in the first 18 hours after the end of phototherapy, there's a sort of a rearrangement all over the skin. And so there's a much higher mistake and a much higher underestimation by measuring skin bilirubin compared to the total serum bilirubin. So all in all, what people are doing in the nursery? Well, it's very easy. Have a nomogram, the closest possible to the population we are taking care of. Do the skin bilirubin measurement and draw it on the nomogram. If we are on the lower risk zone here on the right, and there is no rate of rise between two measurements above 0.1 milligram per deciliter per hour, so no crossing centile behavior, discharge without follow-up, the baby is okay. Conversely, if we are not on the very low area of the nomogram and or there is a crossing centile behavior that I mentioned, we need a follow-up. Maybe the baby cannot go home right now. We need it to be checked tomorrow, okay? And besides, this has been extremely useful also for preterm babies. Now we're taking care of babies that are as small as 400 grams. So you can imagine that in these babies, even drawing some ml, some microliter, it's dangerous because they don't have so much. And you see here, Finn Ebsen, 20 years ago, demonstrated for the first time that transcutaneous bilirubinometry is extremely accurate, also in extremely preterm babies, irrespective of gestational age, hematocrit, and other comorbidities. And even using it, approaching to the threshold within the 70% of the phototherapy threshold. And this allowed to spare a significant number of blood samples, as you can see from this cartoon here, and at any gestational age, actually. And this is what we do. We calculated here in this paper that has been published many, many years ago, that we've been able to, you see here, to avoid like 58, almost 80% of blood sample in preterm babies, which is very much significant for this population. These were preterm babies, but more recently, 2019, we tried to do the same in extremely preterm babies, so those below 1 kilo. You see here with a median birth weight of 927 grams. Well, the situation is the same. I'm always bothering you with the same type of scatter dot plot. You see here is always the same, and we've been able to spare a lot of blood samples. Now, it's all over. Transcutaneous bilirubinometry solved all problems about neonatal jaundice management? No, indeed, no. We do have a lot of problems, indeed, yet, because we do have a lot of uncertainty. For example, once I showed you the nomogram to decide about phototherapy, I was referring to term babies, 37 and above. There are a few that are also touching the near-term babies, like 35, 36 weeks of gestational age, but those are practically at term. For all the others, I must say that we do not know anything. We are completely blinded. There is no nomogram. Everyone has his own nomogram, his own policy based on basically nothing, the local opinion. Phototherapy is used in preterm babies, but there are only 2 trials that have been published. One said that you actually reduce phototherapy, you reduce bilirubin, and you improve the neurodevelopmental outcome of preterm babies. The other one states that, yes, you do that, but in sicker babies, you increase mortality. So it looks like you do phototherapy, and if this is not killing the patient, then you can improve the neurological outcome. So you can imagine that we are really, really blinded. One of the reasons why phototherapy might be dangerous for extremely preterm babies is that they have such a very thin skin that is very much translucent when it goes down to 400 grams babies. And so the irradiation can not only reach maybe the skin, but also somehow the internal organs, creating oxidation, and that oxidation can unfortunately be deleterious and trigger inflammation all over the body. We actually measured in a paper that I didn't have time to show, but you can find it under my name in the European Journal of Pediatrics, the depth of the skin at different gestational ages, and found it correlated with the risk of mortality. So it may be the case. But as I said, everyone is doing phototherapy in preterm babies according to his own protocol. Here is the situation. Those are several protocols across the world for phototherapy in premise. The NICE, National Institute for Clinical Excellence Protocol from UK, the Sikh Children's Hospital, University of Toronto, Pillai is from India, the Royal Melbourne Children's Hospital, obviously from Australia, the Dutch Neonatal Society guidelines, Jeffrey Meisel's recommendation or opinion anyway from the US, and the curve, the nomograms from the Italian Neonatal Society. We studied 42 extremely preterm babies, okay? And according to the different level, by checking them with transcutaneous bilirubin every single day, according to the different level, and according to the different nomograms, we, let's say, check it, how many hours of phototherapy would these babies have got depending on the nomogram used. And you can clearly see here with the colors that the UK nomogram is the most aggressive one with a lot of red. Some babies getting 3 days of phototherapy, 72 hours, many 48, and the other a little bit less with the two milder protocols, being the Australian and the Italian one. And all the differences in terms of median duration of phototherapy are extremely significant, as you can see here. So who's right here? The Britons, the OC guys, or the Italian guys? Well, nobody knows. This is going to be published very soon, so it's under review. Don't take pictures, but it's just a call for action because we need to do much more research about jaundice in preterm now that we know about term babies. And beside that, regarding phototherapy, phototherapy is efficacious for two things. First of all, because of the wavelength that nowadays is narrow enough to target the peak of light absorbance of bilirubin, right? Between blue and green, more or less. But also because of the exposed surface area, right? So the wider the surface area and the higher would be the phototherapy efficacy. Now, there is a concept that is called spectral power, which is calculated by multiplying the exposed area to phototherapy times the irradiance given by the device, given by the light. Here we tested with a certified photometer 7 different LED phototherapy devices used in my neonatal intensive care units. And you can see that basically they are almost at the same level for most of them, but still there are 2 devices, one that is significantly down and the other that is significantly up compared to all the others. And believe me, the French regulation for medical devices is very strict. All these devices are checked regularly, and the LED devices are not, let's say, reducing their performances across the years like the classical lamps with bulbs. That means that there is also an engineering problems because of obviously the dose of the therapy that we are giving to these babies may be significantly different. And this is something that my colleagues should understand, because when you give an antibiotic, when you give norepinephrine, when you give, any type of drug in a neonatal intensive care unit, you prescribe a dose, and you want this dose to be given to the patient. Unless we measure every single day irradiance and estimate the surface body area, we do not actually know what is the dose that we are given to these tiny patients. And being so tiny, some difference that do not seem so big may be actually very important. Now, what happens when everything fails? And so I'm finishing my presentation. It's just about the small history that I reported at the American Congress, the Pediatric American Society Congress 1 year ago. That's a case, as I said, that was coming from a small maternity, a spoke, let's say, unit. The baby was discharged without not so much control. It was very yellow. The parents showed that it was not very much reactive after a day or so. They rushed it to the emergency room, which is exactly what should not be done, because the American Academy of Pediatrics recommendation states that if a baby is very yellow, not responsive, or with seizures, must be brought directly to the neonatal ward, not to the emergency room, because it's a lot of lost time. And the baby got like 39 milligram per deciliter, more or less, bilirubin. So it was rushed in ambulances by my mobile NICU to our NICU. It was obviously an AB0 alloimmunization that was completely missed by the spoke hospital. Upon admission in our neonatal intensive care unit, as you can see, the unbound bilirubin was extremely high. The bilirubin albumin ratio was also very high. The bind score was a score, let's say, depicting the neurological situation was awful, and the baby was having seizures. Okay, so it's a very bad situation. We immediately started intensive phototherapy just for the time needed to retrieve the whole blood. And we immediately did arteriovenous double volume exchange transfusion, which is supposed to have an efficacy of more or less 75% classically in reducing the bilirubin level. And so the bilirubin level went down from 40 more or less to 18. And then we also added another therapy that I didn't mention before, the intravenous immunoglobulin, the IgG. That's a very powerful therapy when it comes to alloimmunization, because giving a huge amount of immunoglobulin is going to bind the immunoglobulin circulating and produced by the alloimmunization against the red blood cells, and so it's blocking at the basis the production of new and further bilirubin. And so you can see how the bilirubin went down in the following days, but never, never, ever in life a baby should be exposed to such a higher levels of bilirubin. If you want to know how much 40 milligram per deciliter bilirubin is in millimole per liter, just multiply by 17, it's really skyrocketing. At that point in time, there are a lot of technical problems to save these babies' lives, because at 5 days of life or so, when a baby coming from home, it's not possible anymore to cannulate the umbilical vessels, which are, let's say, the easiest ones, and which also represent the commonest way to have a central venous access in an emergency situation in a baby. So not everybody is able to do otherwise, and many babies would have died in this situation just for the lack of vascular access. Now, thanks to the ultrasound, the 4th level NICUs like mine have the capability to cannulate jugular veins and even subclavian veins on the thorax, which would have been a very dangerous procedure if performed blindly without the ultrasound. And I'm going to show you what we did. So that's the history, as I said. He went at day 7 in the NICU, and hopefully we saved his life. You see here the jugular vein cannulated, and here in the video you can clearly see the jugular vein on the top and the carotid artery, which obviously you don't want to touch, on the bottom. So the fellow is sticking the needle that you will now see all over the jugular vein, actually just beside the jugular vein, so in the wrong direction. And you see the needle here. You see the needle diagonally. Okay, so it's not into the vein, it's beside the vein. So she's retracting the needle, and then she just moving it a little bit until it's puncturing into the vein. Now it's into the vein, so a guide can be inserted, and finally the catheter can be inserted. And you see here on the right in the picture once the catheter is in, there is blood coming out and coming in because we are doing the exchange transfusion. And this is what actually saved the baby, who I can tell you had a normal MRI, normal EEG, and a completely normal follow-up. So I'm stopping here. It's difficult for me to, resume many different concepts and something that is happening in a very small niche area of medicine. But I hope just to have a little bit increased your interest as a sort of an appetizer. And then if you want to know more, you're more than welcome to write me here. There are my emails. And anyway, I'll be happy to take your question over the next 10 minutes. Thank you.